Ellen is back to talk to us about an important subject that is new to the conference this year, but which indicates, I think, a very exciting new kind of research. And this is cholic acid treatment in patients with SLOS. One more time. And also, William B. Rizzo should be recognized, Department of Pediatrics and Child Health Research Institute, University of Nebraska Medical Center, Children's Hospital and Medical Center in Omaha, Nebraska. But first, one more time, again, one of the heroes of SLOS research, it's Professor Ellen Elias. Dr. Elias.
Thank you so much. Well, it's a pleasure to be back talking about a hot topic, which is something new for this problem for Smith-Lemli-Opitz. And Dr. Bill Rizzo, who's here at this conference from Nebraska, and I had the honor of looking at the use of cholic acid in patients with Smith-Lemli-Opitz as a pilot study. It was funded by the NIH as part of a consortium of doctors who treated diseases related to sterol metabolism. It was called the STARE Consortium. And our question in using cholic acid was, would this be a beneficial medication to help patients with cholic acid? The reason we thought about it, we thought that it might, is, and you've heard a lot about this today, cholesterol is needed in your body for making many, many different things. And one of the important things, Dr. Sundaram called it liver juice, bile acids. They are made in the liver and they are located in your intestine and are necessary for absorption of important nutrients. And so we were worried that patients with SLO, especially if the cholesterol was at a very low level, would not be able to make enough bile acids to sustain good nutrition. So we did what's called a pilot study. It's a small study that was looking for two main things. Was giving this a particular form of bile acid, was it going to be safe to use in children? And was it going to have any benefit for the children? So Dr. Rizzo and I worked together to figure this study out. We almost got COVID canceled with this because we were going to start this just before the COVID pandemic started in early 2020, and because of that, nobody could travel, nobody could come to visit either Dr. Rizzo in Nebraska or me in Colorado. And so we had to put it off until finally we were able to accomplish this study over the past 1.5 to 2 years. How we designed the study was it was very small. We only looked at 12 patients. There were 8 in Colorado and 4 in Nebraska. And we enrolled patients whose cholesterol levels were lower than 125. If this were a perfect world, I would have looked at cholesterol levels much lower than that. But I just we had a very limited amount of time to accomplish this study because we were given the money and we were never able to use it because of COVID. And then finally, when we could do it again, we had to do it as quickly as possible. So these 12 patients were all patients who were being treated with cholesterol in various forms. Many of them were my patients in Colorado who were on my cholesterol medication that I described to you before. Some of the milder patients took cholesterol orally in their food. Some of them were on the cholesterol powder. So on this cholic acid medication, we very, very carefully kept the amount of cholesterol constant. We did not change the dose of the cholesterol supplementation at all while the patients were on this medication. We followed their growth, their weight, their height, their head circumference. There was a dietitian involved in this study, one of my wonderful dietitians in my clinic, who did very detailed analyses looking at not just the cholesterol intake, but all the other nutrients necessary in a child's diet. And then we performed lab work at baseline when the patients were first started on the cholic acid. At 1 month, the 1 month test was done locally because patients came from all over the country for this. And then 2 months after being on the cholic acid for 2 months. And then the cholic acid was stopped after that 2-month period. And then 1 month after stopping the medicine, we did all of these lab parameters. Again, some of these lab tests were looking at things like liver tests because we wanted to make sure there was no change in liver function on cholic acid. We got detailed information from patients about symptoms like diarrhea, which can sometimes be a side effect of cholic acid if you give too much. And so we got a lot of detailed information on all of these dozen patients and treated them with this cholic acid for this short time frame. And I know I know that metabolic pathways are very scary, but this is an easy one that I think you all recognize, which is that through this very, very, very complicated pathway to make cholesterol, the block at the final step of trying to convert 7-dehydrocholesterol to cholesterol is where the block occurs if you have Smith-Lemli-Opitz. And then that cholesterol is necessary to make lots of things, including bile acids. And then we know that dietary cholesterol can certainly impact a person's cholesterol level. Also on this slide is an arrow going to the right from the precursors, the 7 and 8 dehydrocholesterol, to make these oxysterol compounds, which are toxic sterols that we know now cause some of the symptoms and problems that a person can have if you have SLO. So the idea of putting this whole pathway together is if we could figure out a way to have the cholesterol levels become higher and not so incredibly low, our hope was that the liver would stop trying so hard to make more cholesterol, but instead just getting to the part below, just above that block, that X, and make more precursors instead that were converted into oxysterols. Now, the process of converting the precursor 7-dehydrocholesterol into oxysterols, that process, that chemical process is called oxidation. So if you give antioxidants, you can slow down that process. And so part of what we were looking at during this study are what your levels were of cholesterol, of your precursors, of the oxysterols, and to see if we could make these levels become more normal by decreasing the precursors, decreasing the oxysterols, and increasing the cholesterol levels. That was our goal. I know it's complicated, but I think you're all smart and would understand that goal. So what were our results? What we did see, and we were gratified to see this, is after even just this short period of time on cholic acid, excuse me, we're able to see a statistically significant increase in the cholesterol levels from a mean of 75 to a mean of almost 100. There was one of the patients, my sweet little girl I've been following now for years, who when she came for a follow-up appointment had a very severe febrile illness. Her temp was 103. And during that visit, when she was so sick, all her cholesterol levels really dropped significantly below what they might have been otherwise. So she was the outlier. But in 11 out of 12 subjects, we did see the cholesterol levels go up higher. What we did not see, which we were hoping to see, was a drop in the precursor levels and what I call the sterol ratio. So when I follow my patients with SLO, I'm looking at how much of their cholesterol is actually cholesterol and how much is actually the precursors. Because the more severe the diseases, when you have SLO, your cholesterol level is lower and you have this higher level of the precursors, so your ratio of how much of your cholesterol is really cholesterol is much lower. It's made up of the 7 and the 8 dehydrocholesterol instead. So I do this, it's just a very simple equation of looking at trying to see an improvement in the sterol ratio. So we didn't see a big change in that, and you know, as we've been thinking and talking about it, is it because we didn't use the cholic acid long enough? Is it because we used the lower end of the recommended dose? Did we need a higher dose to see more of an effect? I don't know. What we did see, which was gratifying, is that the patients gained weight better than they had before. So there was an increase in their weight. And what was also gratifying is that the cholic acid was very well tolerated, and we did not see any drug-related side effects, adverse effects. And I'm just going to show you this pictorially. Excuse me. So the top left are cholesterol levels, and people went up except for my poor little girl with the star there who came in with a temperature of 103. And then the 7 dehydrocholesterol levels, some went down a little bit, some went up a little bit, some stayed the same, but same for the 8 dehydrocholesterol. But there wasn't a change that was significant. And then when I looked at you know, the total amount of precursors, they really did not drop in a significant way. This is a slide with data supplied by Dr. Lieben Zhu. I hope many of you have met Dr. Zhu. Dr. Zhu is a researcher here in Seattle who studies oxysterols. And Dr. Zhu has been the person who's measured oxysterols for me with my research. And he measured oxysterol levels in our patients and found a change in these oxysterols, a drop in them on the cholesterol medication, which we were very gratified by. So even though the precursors didn't drop significantly, those nasty oxysterols, which was the main thing we were trying to lower. And if you hear my talk tomorrow, I'll explain a little bit more about how I use antioxidants and how I follow that. But we were gratified that the oxysterol levels, the important ones, dropped. So what Dr. Lieben's group did is they did a statistical test looking at when we first started cholic acid, and then after 2 months on cholic acid, and then again after the cholic acid was stopped. So, and his lab also measured cholesterol, and they were able to confirm that the cholesterol levels went up from baseline on the treatment, but once the cholic acid was stopped, they dropped back down again to pretreatment levels. And for the oxysterols, there were 2 particular kinds of oxysterols, the 7-hydroxycholesterol, which is an important precursor to bile acids, and then the 7-keto cholesterol, which was lower on treatment. So to summarize, this study was just a small number of patients. But what Dr. Rizzo and I were pleased about was that it can be given safely to patients. There was no significant side effects, elevation in liver function, or bad GI symptoms associated with using the cholic acid. We were able to get the cholesterol levels to rise, and the patients grew better. But there's still a lot of questions that need to be determined. We need to understand better what's the best dose. We used a dose of 10 milligrams per kilogram in the patients for 2 months. Is that enough? Do we need a higher dose? That's the recommended dose in pediatric patients, which is why we picked it. Between 10 and 15, but we went at the lower end of things. And then how long does one need to use cholic acid for it to work? Now, I can tell you that back in the 90s when I was still practicing in Boston, I used cholic acid in my patients with SLO. And I used it quite safely and successfully and was able to raise cholesterol levels up higher than just with the cholesterol alone. And eventually, over time, the precursors dropped. And then what happened is the company that made cholic acid at the time stopped making it. And then for over 20 years, long time, cholic acid was just not available at all. I couldn't find it, I couldn't order it or prescribe it. And then I was thrilled to hear that a company started to make this again. The companies that makes it now are wonderful people. They are here today. The company is called Travere. And they have been so supportive of this idea of being able to help patients with SLO. So they supplied the cholic acid for this study, for which we are greatly appreciative. And I have been using it now in patients with SLO, not everybody, but certain patients with SLO since the study ended. It is approved by the FDA to use in pediatric patients. With SLO and with liver problems, which many patients with SLO have. And so I have a subset of patients who have quite severe disease in Colorado whom I follow, and who a couple of them did well on this pilot study. And so because their levels of cholesterol fell back down again as soon as the cholic acid ended, and I have been able to prescribe cholic acid for them. In some cases, insurance will cover the cholic acid, and that has been very helpful for a lot of my patients, and I'm grateful to Travere. They have been giving a 3-month trial of patients that they've been giving the medicine to see how patients do on it, and I was told that there will be 2 times that patients could speak with Travere and find out more information about colic acid if you would like. And those 2 times are 5 today and 10:30 tomorrow morning. That there will be people available for Zoom conversation about colic acid. I think what is, and I have just some information I wanted to quickly share about a couple of my patients that I've treated with colic acid recently. So this patient has pretty severe disease. She also has severe liver disease. She is G-tube fed. She's a very, very tiny person. She weighs about the size of an 8-year-old, and she's in her late 20s. What made me want to start her on cholesterol? Just trying to see if I can figure out how to do the, which button do I press for the arrow?
The laser pointer.
This one? Okay, let's see if I can. Here we go. So right up here are her blood tests that this is pre-treatment. So these are the 2 main liver tests that we follow, AST and ALT, and normal is less than around 35. She was in the 200 range. And this GGT test is a 3rd liver test that we follow. And again, normal is about less than 20 or so, and so she was above 400. Her cholesterol was in the 70s. Her 7-DHC was almost 52, and 8 was about 8. And her ratio, that's how much of her cholesterol was made up of cholesterol versus precursors, was only about 55%. And then she's been on Cholbam now for almost 6 months. And so you can see that her liver tests have come down fairly significantly. Her GGT has also come down, not normal, but not so scary either. Her cholesterol hasn't changed a huge amount, but her precursors have, and her ratio is better. And her weight and her body mass index have increased from 31 to 35 kilos, and her BMI has gone from 14 to 16, still very thin, but improved. And her overall health status is better. This is a second patient that I put on colic acid. This is a teenage sweet boy who I've been following now since he was very small. He has moderate intellectual disabilities, pretty significant behavioral issues along the autism spectrum, including aggression and self-injury. He has had serial eye studies that have showed retinal disease that are impacting his rod and cone function. And as I'll explain to you tomorrow, that can be helped by using antioxidants. I have treated him with cholesterol plus antioxidants, which has led to improvement in his retinal function. So for him, he has had fairly nice and normal looking liver function all along, so that was not my main indication for treating him. But his cholesterol was below 100. And so I've been able to get it pretty nicely up, 110 or higher. He's going through puberty as a teenager, and his height has really had a big improvement in that. His weight has been really stable, though, so he's more proportionate than he was before. And his ratio has very, very slightly increased. He has tolerated the medication very nicely. So to summarize my experience with Cholbam, which is the name given to colic acid by the folks at Travere, I feel that it's a very safe and helpful medication to use as an adjunct to cholesterol supplementation in patients with Smith-Lemli-Opitz. And in my mind, the indications that I would think about using it in are my patients who have significant issues growing, who have feeding intolerance, who have liver disease, and who have cholesterol levels that are lower than 100. It has been very well tolerated, and in this small pilot study, and the patients I've been treating subsequently, I've been able to see a stabilization in liver disease, cholesterol levels, which are improving, and improved growth. I put some references at the end of my talk, and I think you'll get to see these slides. But I wanted to particularly give a big thank you to Dr. Rizzo, my partner in this endeavor, who's just a wonderful, brilliant, smart doctor who's really devoted to his patients. He's in Omaha. And particularly to all of the patients that I've been working with who traveled from very, very far away to participate in this study, and were willing to try a new medication to try to help their children. We really, really appreciate you as families when you're willing to participate in a research study like this. Where we would like to go from here. I think that the way that you prove that a medicine works to help a disease is called a double-blind, placebo-controlled study. And that's where you give patients medicine and you give them a placebo that looks like the medicine but isn't. And then you study them and you follow them and you see, is there a difference between the medicine that you're giving and the placebo that shouldn't have any effect? And we talked last night at our board meeting about wanting to look at cholic acid in this way so we can really show that, that it's helpful. I have patients who have cholesterol levels in the normal range, right? I would not use cholic acid in them, who are growing quite well and are well nourished and are tolerating their diets. I don't think that they need cholic acid. But I have patients who have very, very severe disease, who have very low cholesterols, very high precursors, and no matter how much cholesterol I try to give them, it's been challenging to get their cholesterol levels up. And in those patients, I would really like to show that cholic acid works. In our pilot study, we only looked at children who were over the age of 2. We looked at kids between 2 and 26, and we did that purposefully because sometimes some of the littles, some of the really small young children, are very medically fragile and have lots of other medical issues going on that would have made it not so easy to travel with them or safe. And so that's why we started with kids over the age of 2. But cholic acid has been safely used in newborns and very young infants who have other liver diseases. So it's not that you can't use it in very small children. And in fact, I think that's one population that it might help the most. I used it that way in Boston. The other thing is how to give it. Because cholic acid comes as 2 strengths of capsules. Not too many kids that I know who are G-tube fed can swallow a capsule very easily. So what we had to do is figure out a way to turn these capsules into a liquid form. And the dose was based on the child's weight. So we could give that 10 milligrams per kilogram of weight, dose per weight. And so I have a very brilliant pharmacist who's part of my clinic, and he figured out this method where we taught patients very successfully and easily of opening up the capsule, putting it in, we often use the whatever formula the child was on, and you'd mix up the cholic acid with a very specific volume of liquid, and then administered an amount of that, divided into 2 or 3 times a day. We tried to make the math easy, so that we could give that child 10 milligrams per kilogram per day of the cholic acid in a liquid form. All of these 12 patients were able to tolerate it that way. A couple of my older, bigger patients who could swallow capsules, we figured out the dose to make the capsules dosage work. So it is possible to give it as a liquid form for smaller children who are G-tube fed. So I will stop there and ask for questions. Yes?
I have a question.
Here, let's get you a mic.
Mark's got it.
Hello, I have a question because as I understand correctly, the Cholbam is in form of pills, and my question is it 100% cholic acid? And so is it the same product as, for example, the cholic acid in powder that Merck does?
So I am not familiar with cholic acid made by Merck as a powder. I've never used that.
Oh, it's a
and
powder.
I don't know how it's dosed.
Ah, okay.
I mean, I don't know how many milligrams in
No,
say,
it's
a spoon
100 pure cholic acid in powder. Merck
But
says.
how do you figure out the amount, the dose in the powder?
It's a ready product that you can buy from Merck, cholic acid. I actually have done it when I read about your studies, and I have it home, and it's in the form of powder, and it's supposed to be 100% cholic acid, and I was wondering, is it different from the pill?
I don't know, because I'm not familiar with what that product is, but here's what I'm thinking. I think that to prove that it really works, it will be important to show that in a scientific way. And so what we were talking about at our board meeting is having 4 sites around the country where we could think about developing a protocol to do that. Not everybody with Smith-Lemli-Opitz needs cholic acid, right? So, yeah, kind of, I just want to make sure that people aren't giving their child a medicine that's not necessary. But then to know that, like all medicines, they have beneficial effects and possible side effects, and making sure that a physician is recommending an appropriate dose for the child and what they need. And then following it, right? Because you need to follow and see what's happening to the cholesterol, what's happening to the precursors. Doing that is not always so easy because those tests have to be done in special labs, yeah? And so I think that this is going to prove to be enormously beneficial for a subset of patients. And I'm very, very excited about that, and I'm excited and grateful to Trivier for helping to partner with us to look at this in a careful way and to show that it'll be helpful. But it's not a cure for Smith-Lemli-Opitz, right? And I'm not sure I think of it as a treatment all by itself.
Thank you for that question. We've got another question over here.
Doctor, were you able to get any input on insurance trends for the patients that were approved? What were they asking for?
Right.
What was successful?
That's a really good question. So in Colorado, where I practice, many of my patients with medical complexity have either Colorado Medicaid insurance or Medicaid insurance as a secondary to the private insurance that the parents carry. We have had good luck having Colorado Medicaid pay for our patients. There have also been some private insurance companies that have agreed. I think it's been a little bit easier to get approval in those patients who have liver problems, because liver disease is one of those problems that bile acids have been used for a long time. So if you can show the child has liver disease, then it was easy peasy. But I think that's a good question to ask the Travere folks, maybe, because I don't. I know for the majority of my patients that I wanted to treat with cholic acid, I've been able to get insurance to pay for it.
Thank you.
So that has been good.
And that's a follow-up question online too, is if it's approved by the FDA, then why is it so difficult to get insurances to cover this? And that's...
This is true for lots of things, right? If you have a child with severe nutritional deficiency who's G-tube dependent and you have private insurance, will they pay for your child's formula? Very often, no, right? And it's nutrition, it's a basic that your child needs to survive. And private insurance will not pay, but Medicaid will, right? It's been one of the mysteries to me my whole career. But it is, it is what it is. So.
There are a few questions online too, if I can.
Okay, sure.
So there's several. So when you say severe SLOS, is this in patients that have more of the characteristics of SLOS, or the labs that show the severity of the gene?
So that's a good question. So when I'm looking at patients and assessing their severity, it's, in my mind, a combination of factors. The Severity Score that was described a little bit earlier as part of the NIH natural history study is based on physical findings and birth defects at birth. And it, while it is true that patients with more severe disease and more severe cholesterol deficiency, where the enzyme really is not working very well, tend to have more of those birth defects and severe problems. But when I'm looking at it, I'm looking at a combination of the biochemical tests, how low is the cholesterol, how high are the precursors, what's the ratio. I'm also looking at the patient's status in terms of their nutritional status, because I think bile acids will really be an important tool in my toolbox for helping patients with significant nutritional problems. And so I think those are the things that I'm basing on both a combo of physical features, nutritional factors, and biochemical studies altogether.
Thank you. Another follow-up question from the FDA. Is this FDA approved generally for other things, or is it specifically approved for use with kids that have SLOS?
That's a really good question. So Cholbam is used for other disorders, not just SLOS. There are some rare genetic disorders for whom it's patients for whom it's very helpful. And so SLOS is not the only disease for which it can be used.
Okay. Another question, what is considered to be low liver levels for children with SLOS?
So if there's a problem with the liver, and Dr. Sundar mentioned this in her talk somewhat, there are these chemicals called transaminases. and they become pretty elevated. And some of the very, very severe patients that I lost as very young children had very severe liver disease. Their liver just did not work. They had very high levels of transaminases, but also developed an inability to process their bilirubin, so they became quite jaundiced. And so we call that having cholestatic liver disease if your bilirubin is very high. And so there are babies with severe SLO who present in the newborn period with severe jaundice and liver disease. And there's actually a genetic panel that's free, and that's how a number of severe patients are now identified, that if the baby has bad jaundice like this and liver disease, Smith-Lemli-Opitz is one of the diseases on that panel, and that's how they're identified in the newborn period.
Thank you. A few more questions. Can you explain further what it means for the gene to take up more of the cholesterol than a normal person who does not have SLO? And there's some confusion of what, when you say SLOS, taking up levels and numbers.
I'm trying to figure out what that question means. Can anybody help me with that? I'm a little confused by the question.
Yeah, and we can table that one too.
Okay,
Yeah.
I'm not sure I understood the question.
Okay, I'll ask for clarification then.
Sorry.
Yeah, no worries, no worries. Next question, are there going to be any future studies? If so, will we sacrifice our possible participation in future studies if we're already participating in one now?
Future studies for cholic acid?
I think that's what they're referring to, yes.
Okay. So as far as I know, the study that Dr. Rizzo and I did that was supported by the STARE consortium is the only study in this country that's looking at using cholic acid in patients with SLO. And what we had a very animated conversation about last night during the board meeting is how to make this drug more available to those children who would really benefit from it, but also try to figure out who those patients are and show that there really truly is long-term sustained benefit from this drug, that we find the right dose, that we have found the right way to administer it, and that maybe we were just really lucky that nobody had any side effects, but we want to make sure that what we do is safe for patients as well as beneficial.
And a couple side effect questions as well too. This person's daughter took it for almost a year. She got very ill and never put it back on it out of fear. Have there been any serious side effects from that?
Mm-hmm. So again, I used cholic acid back in Boston in the mid-1990s, and then by the late 1990s, it was not available anymore. And then it wasn't until, more recently that we looked at the study post the COVID lockdown. So there's not a huge amount of data about this in patients with SLOS.
And last online question, or actually there's this one more that came up. Does this make the acid reflux problems worse? And does omeprazole,
Omeprazole.
thank you, diminish affect cholic acid production?
I don't think it makes reflux worse. Reflux, again, as Dr. Sundaram showed you on that graph, reflux is a problem in little infants, and it gets much better as you get older. I remember my oldest, who's now 39 and a math professor, he had such bad reflux that My father-in-law told me we should wring out our rug and we could feed a whole tribe in Ethiopia. It's a really common problem in young children, but it gets better as you get older, and it's not just SLO, it's all children. Because our study looked at kids 2 and up, the problem with reflux would have really gotten much better by then in most kids. Omeprazole is one of those medicines that's also called Prilosec. It's one of those medicines that blocks the stomach from making acid. And so in some children, the discomforts from food coming back up from the stomach into the esophagus, which normally doesn't ever see acid. Some of that discomfort improves when you put the patient on a medicine that blocks the stomach from making acid. But the cholic acid is working way down the GI tract, right? It's working in your intestine. So it should not have any impact on reflux symptoms.
Okay, I think that answers the next question about using Tums. Is it okay to use Tums with this? So
Yes.
I think you just answered that. I think I have the follow-up question from previous. Here's some more information on that previous question. Hold on, I lost it again.
Sorry.
Thought that was me for a second.
That woke you up.
So I think this is a couple more clarifying questions, I believe. She speaks out about cholesterol being taken up by the gene. How do they determine what amount of those numbers are the gene? I think that's a follow-up question from that previous one.
Yeah, that's a little confusing.
Okay.
The gene tells your body how to make this enzyme that you need to manufacture cholesterol in your body, okay? The gene that is problematic if you have SLO is at the very, very final step of this very complicated long pathway to make cholesterol. And so when you have that gene not working, you cannot change 7-dehydrocholesterol into cholesterol. Okay? Hope that helps clarify.
I think so. If not, we'll ask another question on that one. Oh, she said that answers it. She said thank you.
Oh, good.
So another example, a child has a cholesterol level of 100. Is she saying that we should give eggs because that is not the true number? Just trying to understand their response.
Okay. So whenever I get a gazillion calls all the time or emails and so on from either patients or physicians taking care of patients who have SLO. And they say the cholesterol is this, what should I do? And my first question is always, where was that level, what lab was that level done in, right? Because if it was done in just the regular hospital lab, wherever that patient lives, that level of 100 is probably not all cholesterol. It's a mix of cholesterol plus 7 plus 8 dehydrocholesterol altogether, because the lab test that's done in just a regular lab, not a special lab, cannot distinguish between cholesterol and the precursors. They all look like cholesterol in a regular lab. That's why you need to send testing to a specialized lab, and as Bob Steiner explained this morning, there are several now all around the country that can distinguish the 7-dehydrocholesterol from cholesterol. The lab I've used for the last 30 years is the Kennedy Krieger lab at Johns Hopkins. And what I like about their assay is they don't just give me the 7-DHC level, which that's all you get from Mayo, for example. But the Kennedy Krieger lab gives me 7-dehydrocholesterol, 8-dehydrocholesterol, and cholesterol level in one blood test. And I need all three of those to decide how much cholesterol does the child need, and should I think about cholic acid.
And last question thus far, is that you state that one of your questions is how long a child might need to be on cholic acid. Can you talk to this? Are you thinking months or years?
That's a good question. At least months. I want to get the cholesterol level up high enough so that there's enough cholesterol present for the body to be able to make its own bile acids, right? The level I sort of think of in my mind to shoot for is about 125. That's the level I'm trying to get patients. But sometimes if someone's starting with a cholesterol of 30, if I get them up to 50, I'm doing great. It really depends, as I mentioned earlier in my prior time I stood up here. Every patient is an individual and has a different set of features and things that I need to think about and how I can best help them. And that's what I try to do, is individualize what I'm doing for each child.
Thank you. And follow-up question to the cholesterol level. What should she specifically ask for her doctor for what kind of test?
Mm-hmm. So it's a test that can tell us both, not just the cholesterol level, but also the 7 and 8 dehydrocholesterol levels as well. So the precursors. Mm-hmm. Yeah.
Follow-up question about the duration. Have you looked or thought of it all as using this as a pre-surgery boost? My opening,
So that's a really good question. If someone is going through some huge procedure like a heart surgery or a spinal fusion or something like that, yeah. And it's been really, really hard to get a cholesterol level up high enough, I would definitely think about it. I'd also make sure if the cholesterol level is really low that the child is getting stress steroids too around the time of any major procedure that's planned. There was a topic that Gretchen had asked me to talk about it, and I don't think I mentioned it strongly enough, and I just want to say that there is no IV cholesterol medicine. I can't prescribe cholesterol for you to go to the supermarket and buy it there either, but there's no IV cholesterol medicine. The closest we have is something called fresh frozen plasma, and that's a blood product which happens to be have relatively higher cholesterol in there. And I have used, it's called FFP for short, fresh frozen plasma. And I have used FFP in very critically ill newborns whose cholesterol levels are very, very low, like less than 10, less than 20. If they're nowhere close to being able to feed yet, because sometimes very, very sick newborns can go for a really, really long time before they're stable enough to get anything in their gut, yeah? So I've used FFP infusions to try to get that cholesterol level up to maybe stabilize a kid for surgery so that they can get a G-tube so I can start feeding them and I can start to give them some cholesterol in their gut.
Thank you.
Yeah.
Other questions in the room? As I stand here, I'm just so grateful that Dr. Elias has spent so much of her career thinking about our kids and working on solutions to the specific sort of problems that they face. I'm also grateful to Travere. I think that if we're going to make progress in the future, we're going to have to entice drug companies like Travere to care about our rare kids. We saw in an earlier presentation today that we represent such a small percentage of potential patients out there. And so for them to take an interest in us and to focus all of that research and investment in our children, I'm really grateful for that as well. Yes. And they're here if you want to chat with them about the good work that they do. If there are no other questions, then it's time for a break. It is now almost 3:15, and we'll be back at 3:30 with a talk by Elaine Tierney on SLOS and autism spectrum disorder. But first, one more time, let's thank Dr. Ellen Elias for her comments today.